So over the course of the next 15 minutes or so, I hope to help us learn to apply risk stratification strategies to establish effective treatment plans for patients with pulmonary embolism, evaluate the benefits and risks of new and established therapies to treat venous thromboembolism, determine the optimal duration of therapy and best agent for prevention of recurrent venous thromboembolism, and then to understand the link between venous thromboembolism and atherothrombosis. In 2008, the U.S. Surgeon General estimated that 100,000 to 180,000 pulmonary embolism-related deaths occur annually in the U.S. alone, and that pulmonary embolism is the most preventable cause of death among hospitalized patients. And this is a dramatic example of what we're trying to prevent in patients at risk with venous thromboembolism. This is a pulmonary embolism. You can see on this CT scan, you see the blood clot here in the main pulmonary artery, then going into both branches on the left and on the right. Now, pulmonary embolism really represents a spectrum of diseases. At its most severe, massive pulmonary embolism accounts for about 5% of patients. These patients come into the hospital with low blood pressure, fainting, in shock, sometimes cardiac arrest, or respiratory failure. And if these patients aren't treated very aggressively and very quickly, they can expire. Submassive pulmonary embolism represents about 25% of the pulmonary embolism population. These patients come in actually looking stable. Their blood pressure is fine, but they have evidence of right ventricular dysfunction. The right side of their heart doesn't function well under the pressure load of the blood clot. And these patients, a subset of them, will go on to deteriorate and develop cardiac arrest or low blood pressure. Finally, the largest population of PE patients are those that have normal blood pressure and normal right ventricular function. These patients enjoy a prognosis that's very benign with anticoagulation alone. I've already mentioned the right ventricle as being important to what happens to patients with pulmonary embolism. We know that patients who have pulmonary embolism and a failing right heart have a high risk of mortality. In this study, almost 21% at 90 days. And that's in contrast to patients with pulmonary embolism who have normal right heart function, where the 90-day mortality is about 15%. Still high, but not as high as those who have right ventricular impairment. We can detect right ventricular impairment and use it for risk stratification using the CT scan. If we make a measurement of the right ventricle and compare it to the diameter of the left ventricle, and if that ratio is in excess of 0.9, we identify patients who are at increased risk of dying from their pulmonary embolism. And here we have an example of a patient with milder right ventricular enlargement, and here we have an example of severe right ventricular enlargement where the right ventricular diameter is about 5.3 centimeters and the left ventricular diameter is only about 3.2. Normally, the left ventricle is the bigger of the two ventricles. Echocardiography is also very important for risk stratification. Here we can see some characteristic findings in patients with pulmonary embolism. We see the right ventricle is much bigger than the smaller left ventricle. This septum, or this wall that separates the right and left ventricle, is being pushed towards the left ventricle, creating an almost D-shaped left ventricle. That symbolizes or signifies the increased pressure that's being seen on the right side of the heart, and that actually impairs filling of the left ventricle. We can use blood tests called cardiac troponins to detect patients who are at increased risk for adverse events in pulmonary embolism. Here we can see that no matter whether the patient has right ventricular enlargement or not on echocardiography, an increasing level of cardiac troponin correlates with a higher risk of pulmonary embolism death and all-cause mortality. So for risk stratification, we can use this as an algorithm. Patients who present unstable, in shock, or with a low blood pressure are at the highest risk and require aggressive therapy. For all other patients, we need to look for signs of right ventricular dysfunction. If we find that the patients don't have any elevation of their cardiac blood tests and they have a normal RV on chest CT, then we can just anticoagulate those patients alone and they do well. But in patients that have elevated cardiac biomarkers, we have to look forward, look further using echocardiography to see if they have signs of right ventricular enlargement. Or if the patient has right ventricular enlargement on CT, all of these patients have right ventricular dysfunction and may be considered for advanced therapies, which we'll talk a little bit about. So one of the advanced therapies that's been around the longest is giving a clot-busting drug through an IV. That's called fibrinolysis, or the breakup of fibrin. And the potential of fibrinolysis is to rapidly reverse mortality by preventing RV failure and hemodynamic collapse, by reducing RV pressure overload, by breaking up that clot that's causing obstruction, and by reducing some circulating hormones that actually increase the pressures in the lung arteries. By preventing recurrent blood clots, most patients who have pulmonary embolism actually have blood clots in their legs. And if we can dissolve that sort of deposition or that depot of blood clot in the legs, we can prevent further ones from traveling to the lungs. And then finally, fibrinolysis can help improve gas exchange. Here we see an example of a patient with acute pulmonary embolism. We can see these darker areas are filling defects in the pulmonary artery. And after the administration of a clot-busting drug, we can see now that that pulmonary artery is clear. So with fibrinolysis, we can achieve very quick breakup of that blood clot. And with that rapid breakdown of the blood clot, we can actually return right ventricular size and function to normal. If you see here, this is before administration of the clot-busting drug. We can see the right ventricle is enormous compared with the left ventricle. And after administration of that drug, the right ventricle is returned to its normal smaller size, and the left ventricle is now the dominant ventricle in the heart. Now, one of the reasons why we're always looking for new techniques to break up pulmonary embolism is because systemic clot-busting drugs are associated with a high risk of major bleeding. In a study conducted here, looking at 104 patients with acute pulmonary embolism, we found a high rate of bleeding. 20 patients had major bleeding. One of those patients had a fatal bleed. One had to go to the operating room to stop the bleeding, and then 7 patients had bleeding in excess of 3 units of packed red blood cells. When we look at the location of these bleeds, unfortunately in a large subset we're not able to tell where the patient's bleeding from. Among other patients where we are able to tell, gastrointestinal bleeding, and then probably the most concerning type of bleeding is intracranial hemorrhage, and that can range anywhere from 3 to 5%. Now, we have clinical trials to support the use of systemic clot-busting drugs. For massive pulmonary embolism, again, those are the unstable pulmonary embolism patients, the best study that we have is a small 8-patient randomized controlled trial. This study assigned 4 patients to receive the clot-busting drug streptokinase, followed by heparin, and then the other 4 patients were randomized just to get blood thinner of heparin alone. And what they found was that all 4 patients who got the clot-busting drug survived, and all 4 patients randomized to just anticoagulation alone died. And when they did an autopsy study of the 3 patients randomized to just the blood thinner alone, they found that all 3 died from massive pulmonary embolism with a heart attack involving the right side of the heart. And so based on this very small trial, that's the evidence that we have to support clot-busting drugs for massive pulmonary embolism. Now, you remember that other category that wasn't as severe as massive pulmonary embolism but was still at risk was the submassive pulmonary embolism category. The largest study that we have to validate the use of clot-busting drugs for those types of patients right now is the MOPETT study, and this study showed that in patients receiving anticoagulation with heparin plus a clot-busting drug compared with those receiving heparin alone, there was an improvement in event-free survival. But that event-free survival really just related to the fact that patients who got thrombolytic or fibrinolytic clot-busting drug up front didn't need any aggressive care later on down the line. We're still waiting for some very important trials that should be presented in the next week or so at the American College of Cardiology that might shed more light on whether fibrinolysis is appropriate for submassive pulmonary embolism patients. This was a smaller study presented last year at the American College of Cardiology called the MOPETT study that also looked at patients who had very bulky pulmonary embolism and gave them a half dose of clot-busting drug. And they found that they could prevent pulmonary hypertension, which is the buildup of high pressures in the lung arteries. They could get patients out of the hospital sooner, and there was a low risk of bleeding when compared with standard blood thinning. This is one of the studies that we will be getting results on within a week's time. The PYTHO study, a large European study looking at tenecteplase, another type of clot-busting drug for patients with submassive pulmonary embolism. Because we're so afraid of the risk of bleeding, there's been a lot of research and investigation into other advanced techniques for breaking up pulmonary embolism that might have a lower risk of adverse events. There are catheter-directed therapies, surgical embolectomy, and IVC filters that Dr. Sobieschek will talk a little bit more about in the next talk. So once we get patients through the acute event, we have to anticoagulate. We have to thin the blood so that the remainder of the blood clot can be dissolved. We have options of unfractionated heparin, low molecular weight heparins, which are given through injection. Fondaparinux was another blood thinner given through injection, or something called direct thrombin inhibitors. Deciding which of these immediate agents to give really requires us to understand what procedures the patient might be going for. If patients are going for either the clot-busting drug or a surgical or catheter embolectomy, or they're going to get an IVC filter, which is a basket type of device to catch blood clots, they get unfractionated heparin because it can be turned off and on very quickly when they go to the procedure. Patients that fall into that green category, the ones that have a normal blood pressure and have no signs of right ventricular dysfunction, they tend to do well with just anticoagulation alone, and a low molecular weight heparin or a fondaparinux can be given by injection. And then in patients who were worried about, in the past, have had a reaction to heparin, or were worried might have a reaction in the future, we can use these direct thrombin inhibitors. Once patients are ready for discharge, we have to think about something that they can take easily at home. And for the longest time, that's been warfarin or Coumadin. But we know that warfarin has many disadvantages that we've already talked about. It has a delayed onset and offset. It has a very variable dose response. The therapeutic window can be very narrow. It has many drug-drug and drug-food interactions. It's inconvenient to monitor for both patients and for providers. And then there's a bleeding rate associated yearly with the use of warfarin. And it's for all of these reasons that there's been such interest in these novel oral anticoagulants that Christian's already spoken about. These novel oral anticoagulants have been studied not just in atrial fibrillation, but also in venous thromboembolism. One of the first studies looked at Dabigatran for treatment of venous thromboembolism. This was called the RECOVER study, and it looked at almost 2,500 patients with objectively confirmed venous thromboembolism, and randomized them either to get the usual, which was parenteral, either injection or IV heparin, and then warfarin, or parenteral anticoagulation and then fixed dose Dabigatran. And what the investigators found was that Dabigatran was no worse than warfarin. We call that non-inferiority. There was a sign that Dabigatran might be a little safer as there was less of total bleeding, but there was no real difference in major bleeding compared with warfarin and Dabigatran. Following the RECOVER study, there was the publication of a duo of studies, the EINSTEIN DVT or PE program. This study looked at patients who either had confirmed DVT and no PE, or in EINSTEIN PE they could have a confirmed PE. Patients were randomized either to receive rivaroxaban 15 milligrams twice a day for 3 weeks and then 20 milligrams daily, or enoxaparin 1 milligram per kilogram twice a day and then warfarin to a target INR of 2 to 3. The important difference here from the Dabigatran study is that this can be done completely orally. Rivaroxaban does not require injections or IV heparin. You give a loading dose for 3 weeks, and then you drop down to a maintenance dose. So it's completely oral therapy. And what the investigators found in another study of about 2,500 patients was that rivaroxaban was non-inferior to the combination of enoxaparin and warfarin. And then they did something called a continued treatment study where they took patients where the clinician was worried that the risk of having another blood clot might be high after stopping anticoagulation after the usual 3 to 6 months. And they continued patients in a randomized fashion to keep on rivaroxaban or to go on to placebo. And they found that if you continued rivaroxaban, you markedly reduced the risk of recurrent venous thromboembolism. Bigger study was the EINSTEIN PE study, almost 5,000 patients. Once again, we see that rivaroxaban was non-inferior to the combination of enoxaparin and warfarin. But very importantly, what we found was rivaroxaban was associated with a lower risk of major bleeding. So we're having our cake and eating it too. We are just as effective as warfarin, but with a lower risk of bleeding. One of the important things after we've discharged patients from the hospital is being mindful of the risk of recurrent venous thromboembolism. We know that patients who have unprovoked blood clots have a higher risk of having future blood clots compared with patients who have a distinct reason for their blood clot. And so one of the important things that we do in follow-up is to determine the optimal duration of anticoagulation. Sometimes that's easy and sometimes that's hard. For patients with provoked blood clots where we can pinpoint the exact cause of the blood clot, such as an oral contraceptive pill or major surgery, those patients are treated with a time-limited duration of anticoagulation. Some patients where we can't ever figure out the reason for their blood clot, we call those unprovoked or idiopathic blood clots. In general, the data suggests that the risk is so high over the next 5 to 10 years that we should continue the patients on anticoagulation in an extended fashion. Patients with cancer, we know, have a high risk of recurrent blood clots, especially if the cancer is not cured, if it remains active. And in those patients, we tend to continue blood thinning long-term as long as there's active cancer. The difficult part becomes this gray zone or patients with an indeterminate risk. In that situation, we have to consider some clinical risk factors, and then there have been some studies showing that some other imaging tests or blood tests may shed some light. Now, there's been research done using the novel anticoagulants and their impact on recurrent venous thromboembolism and optimal duration of therapy. I talked already about the continued phase of the EINSTEIN DVT study, recently published in the New England Journal within the last week or so. We have studies showing that apixaban markedly reduces the risk of recurrent venous thromboembolism after the acute treatment phase, and then also that dabigatran reduces the risk when compared to placebo, and then also has been compared with warfarin as well. I mentioned that cancer was a area of particular interest because the risk of recurrent blood clots is so high. This was a pivotal study published in 2003 that showed that anticoagulation with low molecular weight heparins, these are the injectable types of heparins, was superior to oral anticoagulation with warfarin, associated with a 52% reduction in the risk of recurrent blood clots in patients with cancer. So that's really the standard of care. Patients with active cancer get treated not with Coumadin, but with an injectable form of low molecular weight heparin. In these last few minutes, I want to talk about focusing on overall cardiovascular health in our patients with venous thromboembolism. We used to have a sort of tunnel vision approach to this. We used to think that venous thromboembolism was distinct from heart attack, stroke, and peripheral artery disease. We now realize that we cannot afford to have a silo-based type of thinking because patients with venous thromboembolism also can develop myocardial infarction and stroke and peripheral artery disease, and vice versa. Patients who've had a stroke are at high risk for having blood clots, and patients who've had pulmonary embolism have a high risk of having myocardial infarction. And part of the reason for that is that there are shared risk factors. We know that obesity, hypertension, smoking, having high cholesterol, diabetes, a poor diet, stress, and certain hormone replacement therapies or contraceptive therapies increase your risk not just of heart attack and stroke, but also of venous thromboembolism, DVT, and pulmonary embolism. More importantly, we know that pathophysiologic mechanisms, or the changes that go on in the body that lead to these, are similar. Both venous thromboembolism and atherothrombosis, which is myocardial infarction or heart attack and stroke, depend on inflammation, hypercoagulability, and injury to the blood vessel wall. For a long time, we thought that platelets had nothing to do with venous thromboembolism and that they only had to do with heart attack and stroke. But here we can see in this specimen from a human pulmonary embolism where platelets have been stained blue, we can see that this blood clot is laden with platelets, proving that venous thromboembolism is not just something that depends on the coagulation cascade, but also that platelets play a role. And that has really given birth to a renewed interest in the use of aspirin for prevention of venous thromboembolism. And we've seen 2 studies in the last few months that have shown that aspirin may actually play an important role in preventing DVT and pulmonary embolism. In the WARFASA study, we see that aspirin was associated with a reduction in the risk of recurrent venous thromboembolism in patients who had had already one unprovoked event. And in the ASPIRE trial, although there wasn't a statistically significant reduction in the risk of venous thromboembolism, aspirin was associated with a reduction in some very important other major vascular events. And so with that, I'd like to close with some take-home points. First, that risk stratification is critical in order to identify pulmonary embolism patients who might benefit from advanced, more aggressive therapies. Prompt anticoagulation is still the cornerstone of VTE therapy. Optimal duration of therapy and selection of the best agent requires us to assess the individual patient's risk for venous thromboembolism recurrence. And finally, venous thromboembolism and atherothrombosis share common risk factors, pathophysiology, and it now actually appears that they may share common therapies.